and handing it over to Meg. Meg, you are muted. There you go.
I'm unmuted. Yeah, I managed to work a button. Yay. Well, thank you all for joining us today. Welcome. This afternoon, we are going to spend some time together in the first of a series of virtual cafes that are focused on the future of care for children with medical complexity. Please note that we are recording today's cafe, and we will be distributing that recording after the event along with the chat transcript. So you might not want to say anything too critical of your boss or your spouse on today's webinar. My name is Meg Camo, and I am the Senior Project Director at the Center for Innovation in Social Work and Health at Boston University. Oops. There we go. This virtual cafe series has been generously funded by the Lucille Packard Foundation for Children's Health, building on innovative and influential foundation of work on behalf of children with medical complexity by grantees across the country. We would like to sincerely thank Holly Henry and Allison Gray of the Packard Foundation for their thought partnership and support in conceptualizing and realizing the series. We'd also like to thank our interdisciplinary faculty, the majority of whom are family caregivers of children with medical complexity, for their insights and inspiration. I'm going to take a moment now to say just a little bit about the format for today's cafe and those to come. My co-discussant, Bethlyn Houlihan, and I led the Collaborative Improvement and Innovation Network to advance care for children with medical complexity. That was a quality improvement project that was funded by the Federal Maternal and Child Health Bureau. Kara Coleman, our fellow discussant today, was an integral member of the National Advisory Committee for the project and our lead for our family engagement and partnership work. I'll say more about the CMC Coin project in the context of today's cafe in just a moment, but our aim with this series is to broaden and deepen the interdisciplinary dialogue we began as part of the CMC Coin project to new voices, new perspectives, and new partners in care delivery improvement. Each cafe in the series will be an hour long with 5 to 10 minutes, or excuse me, 10 to 15 minutes of presentation time on a specific topic, followed by 5 minutes of Q&A. And then the majority of our time together will be spent in facilitated discussion on 3 to 4 specific discussion questions. Our faculty, which includes family partners, clinicians, policy experts, researchers, and others, will help us analyze and prioritize the main points which emerge from the discussion. We'll then share that information back out to you and the wider CMC community through a variety of dissemination pathways. When we were planning the cafe series, we noted that the community of people and organizations focused on improving systems of care for CMC is relatively small. And in looking at today's registration list, it seems like everyone is here. That's wonderful. We thank you sincerely for your enthusiasm and your interest, but we also want to thank you in advance for your patience. We anticipate moderating a discussion amongst such a large group may prove challenging, but we're going to try and experiment with today's first cafe, and that we'll stay together in the large group to foster a sense of collective community and connection. It's likely that in the future we'll use breakout groups during the discussion portion of each cafe, but bear with us today and we'll see how it goes. To participate in today's discussion, you will either raise your hand using the Zoom toolbar, and one of the moderators will call on you to unmute your line. Please try to keep your spoken remarks or questions short to give as many participants as much time as possible to contribute and get in. Alternatively, if you don't feel comfortable speaking, if you see the queue for speakers is already long, or if you have a longer comment or question to share, please use the chat box. Again, we are recording today's cafe, and we'll also be saving a transcript of the chat. So even if you don't have a chance to speak, your thoughts will be part of the record. We'll also put the discussion questions into a free text option in the evaluation survey that we'll share at the end of the cafe if something occurs to you later that you want to include. Finally, my email along with Bethlyn's and Kara's will be shared on the last slide so that you can reach out to us privately if you wish. This slide shows the basics of the Zoom toolbar and the location of important functions like the mute and unmute button, the chat button, the closed caption button, and the button to raise your hand. We would love it if you kept your camera on so that we can all see each other, but if you prefer to keep it off, that's absolutely fine. Just a few quick words now about the CMC Coin project to give you some context and to hopefully start you thinking as we move towards the discussion questions. The Children with Medical Complexity Coin was a 4-year project funded by the Maternal and Child Health Bureau and included 10 state team quality improvement projects working around the country on systems improvement for children with medical complexity. All of the state teams and the coordinating team at Boston University worked on 3 shared goals: improving the quality of life of children with medical complexity, the well-being of their families, and the cost effectiveness of their care. To learn more about our findings on each of these goals, as well as the 5 project objectives, we encourage you to check out the 7-paper supplement to pediatrics, which was published in January of this year. While not specific to the 3 goals, we identified several high-level learnings with important resonance to the CMC community through qualitative and quantitative data analysis. I won't go through these individually. You can read them here. We will also be sharing the slide deck after the presentation, after today's event. But to summarize, to really focus on the perspective of families and centralize families in our findings, we really found that was important and gave us some specific awareness and some specific directions for where we could go in the future with regard to improving care for kids with medical complexity. So from those high-level findings, we developed a series of recommendations that I mentioned now, not in the context of, well, now we've got it all figured out, we have all the answers, but rather to spark your thinking in the context of building on these concepts and introducing new ones during the discussion portion of today's cafe. The recommendations include more deliberate and routine integration of primary pediatric palliative care principles into standard practice, more patient and family-driven quality measures co-designed with them, holding the perspective of children and families as whole, in valuing not only physical health, but also spiritual, emotional, and material well-being and quality of life. And you can see a reference to value-based care coordination here, which is accountable, measurable, and robust. Other significant improvements to the system of care for kids with medical complexity include emphasizing access to home and community-based services equally with clinical care, better coordination and collaboration between child-serving entities, and standardizing interdisciplinary teams, which include access to peer services, mentoring, and supports. The CMC Coin project was just one example of meaningful family-driven work that's happening across the country to improve care for children with medical complexity, and by extension, the quality of life and well-being of them and their families. You'll get a taste of a current QI project that's happening now as we wrap up today, but we also wanted to draw your attention to one of the biggest and most potentially impactful efforts happening currently. I'm going to turn the floor over now to Kara Coleman, who will speak a little bit about the Maternal and Child Health Bureau's Blueprint for Change. Kara?
Thanks, Meg. Whoop.
Yep.
Back one, please. Whoop. Scoot
This
me.
thing is totally trigger happy, and I apologize. There you go. I got it now.
It's funny because I had a little tag line that I was going to use about the movement in the cafe thus far, because we're moving so quickly trying to get through our quick discussion in the beginning and get to the really wonderful discussion at the end, but also just thinking about all the movement that happened, the innovation, the direction. You know, the CMC coin was the first of its kind for children with medical complexity, and there was a lot of movement and shaping of the field before that, and that came out of the coin, and that moved into and led to the Blueprint for Change. For example, the quality of life and well-being work that we really saw and raised up in the coin led to that being named as one of the key domains of the Blueprint for Change. And if you look at that logo on the right there, you can kind of think of it as a stool, and the 4 legs of the stool of the Blueprint for Change, and how we roadmap that going forward really is, you know, not focused on a particular policy or a particular thing. It's these domains that we have to figure out how to weave in quality of life, equity, access, and financing. And I think Megan or Bethlehem, one of the two, has put in the links in the chat about how you can access more information about that. But we just wanted to mention it as another layer and a movement forward in our discussion. Next slide, please. Oh, yeah. Group activity. Okay, so more movement. We're gonna all move at once here, but we're gonna pause. If everybody could just take 1 second in the chat and don't hit send yet, but just take a second, think of the first sort of your favorite CMC resource or link or one way that you are working to advance the care of children with medical complexity right now. Everybody chat it in, but don't hit send. And when I say send, we'll all do it once and just sort of create the community of work and more movement of change that's going on for children with medical complexity. All right. Hopefully your fingers are rapidly typing. On the count of 3, I'm going to say, everybody hit send. Awesome. Ooh, I love all that. That's great. So everybody hopefully can see just some of the ways we're thinking about and working towards and what we're valuing in advancing care with children with medical complexity. So we've kind of moved through what's been done, the blueprint, what's leading us forward, what's the current landscape. And the next slide, please. I'd love for us to just stop for a second, and I'd love to highlight the article that I think that they're going to put into the chat that was published last year in Pediatrics by Ames et al. That was titled Perceived Disability-Based Discrimination in Healthcare for Children with Medical Complexity. I thought it'd be nice if we really stop and think about, that was sort of a landmark paper in my humble opinion. We know Lisa Iazoni's done a lot of that kind of looking at disability discrimination in adult healthcare, but this is one of the first that really was calling it out in the care of our children with medical complexity and children with disabilities. And it really said that there's sort of a lack of knowledge and an apathy and some assumptions that are made that lead to this discrimination that then in turn leads to substandard care, dehumanization, and lack of access. So I thought we could just pause for a second and think about and know, I think everybody's really familiar with this medical model of disability that's on the left. It's really almost, if you look at it in a way, it kind of looks like care maps that families use. Except the problem with this medical model is that the impairment is the problem, and in part then the child and the family are a problem. And we've created all these circles around the child and family, all trying to help, also trying to fix and cure with a different sort of perception. But these circles around and around haven't really been inclusive. It's created more and more silos that we're all, clinicians, providers, whoever is involved in the life and the care of children with medical complexity, we're drowning in that. And we're desperate. And that's why we're here to how do we bridge these gaps? How do we eliminate the discrimination that happens in the care? And how do we get kids and families and providers and all of us what we need? So I'd love for us to look then at this social model. Very different, image if you're into images. But what I love about this, even though I am not a math person, is that this is an equation. It feels more doable. In this, image on the left, who's in charge, what's happening, it totally depicts the fragmentation of care. And in this social model, the impairment, the disability is part of the equation, but it's not the focus, right? The disability comes from the barrier. And so while the answers aren't in here, it helps us break down what are the barriers. And I think it's really key too that the barriers here, there's not one barrier, right? And the solution, the elimination of disability discrimination and bias, the access to equitable care for our kids and families is not by eliminating one barrier. If we get rid of the organizational barrier, are we there? Absolutely not, because we may still have physical barriers, and we know from that Ames article and our own experiences and other things, we still have tons of attitudinal barriers to overcome, the perception of children with medical complexity not having a quality of life. So this really helps us focus in on, okay, how do we all come together on these barriers? And the work that we're doing now, is it focusing on all of these barriers? Often we're just focusing on one. And so just like the blueprint, how do we break out and make sure that all of these domains, you can't achieve financing of care for kids with medical complexity without also looking at the attitudinal barriers. Why is certain policy or funding mechanisms supporting kids without medical complexity more than kids with medical complexity. I didn't phrase that so well, but you can follow me and sort of progress through. So one last comment I'd make on that, because I know Becklin is about to give me the shepherd's crook to move to, I'm done with my little bit of discussant time, but I think one thing I'd love to plug too is that I think really what is at this sort of core of how do we come together around these barriers. We do a lot of talking about, oh, this is what we should do for kids with medical complexity or to them. But there's that old mantra of nothing about us without us. And I think one of the most powerful and underutilized strategies to getting to that nothing about us without us is the shortest distance between two people, a story. And so using more narrative practices to build narrative competence so that we learn how to listen to and how to tell stories that make change, not just stories told out in air, that stories that drive systems change together. So using narrative practices and narrative medicine might be one way that we can invest a little bit more, include some different strategies to get us to different results or improved results. We're doing a lot of great things, but we want to do more and better. So with that, I will pass it to the lovely Beth Lynn for the next portion.
Why, thank you. As you can see, we really were choosing to take a minute and really just give some very high level framing. We did want to take a few minutes we have just a few minutes to see if there are any questions that people have. And I did see a few in the chat. So I want to just see first if people should continue a life of its own. And one of the questions was really something that Meg mentioned. Can you provide additional information about the broader supports needed? Here, I'm going to turn off my video for a second because I was going unstable. Can you hear me?
Yes.
Great.
Thank you.
Great. Can you provide additional information about the broader supports needed? For example, social, community support, OT, home-based care, et cetera. So I think that's just a clarification about what we mean there when we're talking about broader supports.
Yeah, so if I'm recalling the learnings that we gleaned from qualitative and quantitative data, including a lot of key informant interviews and also family focus groups, the broader supports were defined in a variety of different ways, including, spiritual supports or supports that are relative to people's religious practice, some cultural sensitivity, recreation, families being able to do things that families without children with disabilities and medical complexity are able to do, just so that they can go out and be a family. Being able to have access to other families who are going through similar situations, who are experienced, and who kind of know the pathways and know what it's like to have a child with medical complexity. Those are some of the broader mental health supports, not only for the child with medical complexity, but also for the parents and siblings, was something that came up repeatedly. So that's, if I'm recalling correctly, those were some examples of the broader supports that folks were advocating for and saying that they needed and that were currently unmet needs.
And to mention, we're going to talk more about that in both kind of practical terms, high level, and then have discussion around not just what we can do clinically, but kind of how we level that up as well in systems thinking in our next cafe. There was also just a question about state policies that assist or impede care for these children and families when we talk about that. And I would say that we're going to get right into facilitated discussion and allow for people to have the opportunity to share anything they'd like to around exactly that kind of thing, Shirley. And these questions are designed to kind of draw that out. So thank you for that. And thanks for being super helpful with your response, Meg. So we're going to get into facilitated discussion because we really want to spend the majority of our time there. It really is meant to be an opportunity to consider together actionable strategies, resources, and leverage points for change. So that's really our main goal here. And we want to make sure that we are really not rehashing. We're not trying to do anything about rehashing what was the CMC coin project, or really staying in the place of the seemingly intractable problems that have a very real human impact. Folks are doing amazing work, and it's going to take all of us working in coordination together to move to meaningful and sustainable change. We asked you some registration questions as a backdrop for this discussion, and we will synthesize those and share those back to you after this cafe. And we really want to make sure that we're giving everyone the chance to grab your metaphorical coffee and come on up and just be here together and start to really consider this together. We are trying to think in a different way and do something a little different than what is normally done on a cafe. So we want to make sure that we give everyone the space for collective wisdom to arise, especially for this first cafe. So we're all together in the space, and we're going to experiment with trying to do this with such a large group, as Meg pointed out. So we really appreciate your patience and your willingness to jump in and do this with us, and future virtual trying to make sure we're collecting that breadth and that we're documenting that. There's going to be several ways to do that. So we could type into the chat, because we're going to called upon verbally.
Bethlen, I'm so sorry to interrupt, but you are cutting in and out. And so I wonder if maybe you could turn off your camera, and maybe we can get your audio a little bit more smoothly. I am so sorry to interrupt. Thanks.
I'm so sorry that that's happening. Okay. So I'm going to rely on someone to let me know if you can't hear me still. All right, I'm doing all right.
I'm your number 2.
Better now.
All right, great. Let me know, because I'm looking at my own Q notes, so I can't quite, it doesn't tell me I'm unstable when I'm doing that. All right. So so you can raise your Zoom hand, and also know that the evaluation has the questions in it. So even if you're like, all right, I'm gonna think a little bit and throw my questions into the evaluation. So there are several ways that you can there are multiple ways then that you can make sure that you're able to get your perspective represented as we move forward. And if we don't we're just with this larger group, we're not going to get to everybody, and we hope you don't take it personally if we don't have the opportunity to call on you. But we're going to capture as much of this as possible, and we're recording everything. So we also don't have to solve this all right here, right now. We have collective impact and collective wisdom, but we want to make sure that we're keeping in mind open questions matter as much as actionable solutions. And when we say my whole life is a quality improvement project, that's a quote from a family leader of the CMC coin. It became our catchphrase, because we're looking for creative solutions while we're keeping that larger aspirational vision in mind. We also want to think about, what can we do now? Don't let perfect be the enemy of the good. So there's going to be a Converse sketch, which AKA the amazing Karina Branson, who is also going to be doing discussion, keeping that alive visually for us. And she can spotlight herself as we go, so that you can see what she's doing, which is going to be awesome to help support the discussion. And so we'll allow you to take a look at that, and allow her to make herself big, and you can make her big too. So she just explained in the chat how you can do that. And then the last thing I want to say is that we are we're going to move into the first question now, and we'll just see how we have 4 questions in total, but didn't expect necessarily that we would get through them all. So let's just start by thinking about, since there are so many of us, the first thing that we're going to try to do is just do the question and take a moment before we respond. So I will let you know when we're ready to have people respond, just so that it's not kind of the rush, and we can all kind of process for a minute together before we go ahead and respond. So in doing that, I'm going to ask if you can, then we have the multiple ways that you can respond. And auditorily. We'll check the chat as best we can, but we'll be calling on people in the room and then seeing what might be coming from the chat that we could pull in if we're able to, depending on how much we're getting. And I'll keep the time. So I'm also going to, in case anyone really has to go, I know some people already told me they had to, I'm putting this eval link in here so that you could just have that to move with and start coming up with your thoughts. Okay, so the first question is, where can the smallest change make the biggest difference? And this is attributed to who, McLeod. And we have the 6 conditions of systems change here just to help think about where different points of change can happen. So that's really what we want to give you a moment to just look, think, and then tell us what you think in terms of where we need to go. And I think we're gonna take ourselves. All right, so now we're ready. Everybody can start chatting. We've had a few moments to process and consider. Feel free to raise your hand. I see someone surely has done that. We're going to take a chance to greet each other, and you can see Karina here. And Karina, feel free at certain points to start spotlighting yourself as well. So Shirley, you have the floor.
Thank you. Thank you for hosting this event. I'm very interested in state policy. I work for the Council of State Governments East. And I was thinking one thing that might be helpful, and I'm not sure of this, but a little policy thing would be reducing the pre-authorizations that are needed for different medications and treatments. A little policy in the scheme of healthcare reform, but I wondered if it would make a difference.
Yeah, I think that's exactly, Shirley. I think that's a great point, that it's where are those levers where we can make a difference that could make a huge difference for people in their lives and for continuity of care and for being able to get what they need, their needs met more quickly. So I think that that's a fantastic point, and I'd love to hear. I see there's a lot of stuff coming into the chat. Does anyone have anything they'd want to say to the group in thinking about this?
Hector wave his hand. Is that correct, Hector? Was your hand still waving that you wanted to speak?
I do, but it's not about policy.
No, it doesn't have to be.
It's not.
Whatever that question
Okay.
brings to mind.
Okay, my name's Hector Reisenberg. I'm a parent navigator at Children's National Hospital in Washington, D.C. And mine is less about policy and a lot more about when I look at your model of inferior equals disability. And I wanted to relate it to my daughter, and it has to do with attitude. My daughter is deaf, and she basically grew up with a deficit model in her head. And partly our doing as parents and all the providers around them, trying to get her to kind of, in the end, it made her try to prove herself to other people that she didn't have a deficit or an impairment. So she got cochlear implants. And to make the long story short, there were 2 aspects of her experience. One was academic and the other was social. And the social one was the most difficult because of her deafness. And she was isolated in an oral environment. And the academic, she felt like she could handle it. She could tackle it. And of course, she had me and other people helping her with the academic piece, because that we knew. And so what happened? We sent her to an oral school. She excelled orally, did incredibly well academically, but in the end, that the deficit model really brought her down emotionally. She had trouble being social with other kids, couldn't make any friends, ended up going to an elite university and not being able to do anything because of the social piece. And so to me, it came down to, she's taught us in retrospect that it was about pride, it was about ownership, it was about community, it was about accepting herself rather than trying to overcome something. Now she's going to RIT, and she's in a deaf program that has brought her together with a cohort of kids just like herself. And I think that that is a paradigm shift that seems, it's actually small in a sense. It's just, rather than focusing on what the kids don't know, helping them to focus on what their real strength is, that being deaf is fine. That's my contribution.
I love that. I appreciate the really grounding in the story and sharing your family story. And I think that that's a thread that we've seen when we look at the CMC coin, and really what families are telling us, that there is one of the things that you pointed to is that there's no substitute for being able to connect with peers and people who have been there, because they are able to bring and understand and just that strengths perspective for people. So that brings that connection and helps them to move through. And that's moving from the medical model to the social model. You just had so beautifully illustrated that in experience. And I'm so glad that that's the path that has happened for your daughter.
Bethlyn, I'm wondering, since you just summarized, like, if it's you're cascading upwards and building that, I've just been looking at the chat, and there's sort of two themes that seem to be arising, is that a lot of people are pointing out different aspects of that relationship, relationships, and that is a small change that makes a big difference. And then there's a lot of policy, but also I'm sort of noticing this other thing that, some people are saying, well, I'm not sure this is a small change that will make a big difference, except I think, just a side commentary that's particularly being said on the policy things I see in the chat. But I think the big part of it is that this is maybe not a policy making environment that is so easy to maneuver, and that's a big barrier, versus the changes that are proposed in here about involving families in medical education, or changing little policies, or improving care coordination, or more funding, and things are not really ginormous. They are little things that could make a huge difference. So that's just a framing thing I'm noticing. Oh, there's more hands. Yay, there, I triggered some hands.
Shirley, did you have something else you'd like to say? No, okay. Then I'm going to lower your hand, and I'm going to go to, you can tell me if I said it wrong, Shasta.
Shasta. Hi, everybody. I'm actually impatient right now with my kiddo. So coming to you
And you're
live from the
here.
hospital.
Yeah.
And I'm here because I'm just sitting here and I wanted to learn about this. So yeah, I mean, my background's in journalism, and so I kind of look at things from kind of the systems perspective and the taxpayer perspective. And one of the things that I've noticed is that there's just a lot of funding streams going to our children with medical complexity, and it just that's kind of where everything comes down to, right? We're always talking about reimbursement rates and all of these other things. And I just noticed that during the pandemic, when paid family caregiver programs were more prevalent, certainly in my community, there was just enormous outcomes, not just with each individual family member and each individual child, but even as a community, because we had more resources, we could, help each other out more and provide community outings more and things like that. So, these, like I said in the chat, each individual client child being and their family being able to direct the taxpayer dollars quickly and efficiently, I think it's one of the biggest changes that we can make to our systems that would have really big knock-on benefits down the road. And I think we already saw that. And that doesn't necessarily have to be a paid family caregiver program. There's other things like budget authority programs or waivers, but I do think that paid family caregiver programs are some of the easiest and fastest and simplest policy changes that we can make. Thank you.
Thank you, Shasta. I really appreciate that. There's just a lot happening in the chat. We all know how funding comes into play. and that there are models in the adult world for money follows the person, for that kind of independence with being able to do financing. I also want to note, Meg pointed out there was a lot on administrative burden, which pre-authorizations did speak to, and there's a lot on that relational piece. And there was some other stuff that she mentioned in the chat that I didn't want to lose. We're talking about community health workers, which goes along with that person-to-person support, home and community-based services. So I wanted to mention those because I see those coming up as we're having the conversation, and some of them feel like bigger, but they're not. They're all existing things that we could look at and see how we expand and make better and can improve upon to make the biggest difference. Diana.
Hi, I finally unmuted myself.
You did it.
What's been important, I think, around here is relationships and getting the stories, the narratives out. And of course, we have people that go to Congress, and I've been and taken family stories and photos, but also getting it in the press. And for us, maybe the Washington Post or the Baltimore Sun. And there are different groups of churches here that have gotten together to tackle certain issues like the transportation and letting people know that there are issues for families and kids around certain things. So not that automatically changes things, but it gets the stories out, and there's follow-up in terms of the editorials and what people are talking about in legislative sessions.
And that speaks, thank you, Diana. That's directly what Kara has mentioned and spoke to, is that storytelling and the way that really does shape and shift their mental models, which is part of systems, and their ends up tying them, connecting them, and relating to the value of family, of caring for our kids, of things that it really presences people to that otherwise they can kind of keep out of their view.
Bethlyn, one other thing I noticed, I'm so pleased to see, I sometimes worry that family-centered care is like this lost dying art or just a plaque on the wall in terms of a clinical space or whatever, and something we don't, it's an adjective and a noun, not really a verb, and how we do it. But I think the value of narratives really crafted and really learning how to listen to and what to do with stories will get us to, in the chat, there's a lot of mentioning about family-centered care. And one of my favorite parts of that is the mutual understanding and benefit, right? Because we are all drowning in burnout in this very broken system. And so that narrative really connects us as a way to really make sure we all understand and get everyone else to understand it on the right page, our page.
Yeah.
Right?
Yeah. And I feel like that's a shared space. There's lived experience, and then there is learned and authentic experience, or witnessing this and seeing it and trying to do the very best you can for another human being and not being able to do that, which is just it can be extremely difficult to be a part of, and why we're all here, I think, because we all are part of the shared space of wanting to do more and do better. I want to see if it might be good to move to the second question, because this is fantastic. I see a ton continuing in the chat. Please continue and please share with each other. And we're going to move now to the second question for you and continue with some of the same type of conversation. Please carry on. Everyone's doing great. So I'm going to hand it over to Kara, and I'm going to start paying attention to the chat a little more myself.
Well, you can obviously see, hopefully you can see the question in front of you. How can we think about innovation and improvement differently so as to get improved and/or new results? I think with this question, in a way, what we were trying to think about is, how do here we are as this community of 180 some people across the country together, and we've all got different things going on. how do we bring and share better and more across so that there's not all these silos? That magic or not so magic word we have in the healthcare system is in the chat a ton too. And so that's sort of the other thing with this. How can we think about the innovation and improvement that's happening in North Carolina, or that Shasta was just talking about in Oregon, or that's really not just in Oregon with paid family caregiving, other places? How do we get the groundswell to share? So if anybody wants to raise their hand and give some responses or ideas or thoughts on that, this can be to scalability. I think that's always a question, with how do we move things forward, or just chat about it too. Oh, it's never good when your question lands with complete silence. This is the magic question, maybe too, right? Like, how do we share? How do we get rid of these silos? How do we bridge? Other than a 50-state coin project, quality improvement project, right? Although that's not a bad idea, right? Kate Detweiler. You're on mute, Kate.
Can you hear me now?
Yep.
Okay, great. I am Kate Detweiler. I am the parent of a child with medical complexity, and I am the administrative director of our complex care program at Children's National. So I'm a colleague of Hector's. And one of the greatest points that I struggle with across clinical settings, research, advocacy, and education that I think would take us really far would be a shared definition with an ICD-10 code, because then we're all talking the same language. We're all looking at the same population. We can all have metrics that are interchangeable. And I just really think that whatever it is, whether we're looking at children and youth with special health care needs, and then CMC, or even the CCI population as defined by Renee Boss and her group, we just really all struggle to even come to consensus about who we're talking about. And if we could do that with an ICD-10 code, I think that would open up a lot of avenues for hospital programs, for funding, for advocacy, because then people would know what we're talking about, and we would all be using the same population when we're talking about, like, especially in our area, what DC is doing, to what Maryland is doing, to what Virginia is doing, and then nationally. So that's my idea, which is not new. I'm just saying it.
Well, but I think the more and more we say it, right, is how we get groundswell. And I think that's also such a great example of a small change that would make a really big difference in multiple ways. Like, you're talking ICD-10 codes. That's the key to funding and other things, right, that we want to open. And often we refer to our CMC population as this small little population, except maybe by one definition, but maybe that's not the best way to present. So it's sort of like a marketing kind of thing that comes in there with the science of who are we talking about and how do we get all on the same page about that. Such a great comment. Meg, you were kind of looking like you wanted to say something. Did you want to add in on something on that? No. Okay. I saw, is it Valeria? Am I saying it right?
Yes, you did say it right.
Great.
Thank you for checking in about that. I wanted to introduce myself. My name is Valeria Peterson. I am from Massachusetts, and I work for a nonprofit called the Federation for Children with Special Needs. And of course, when you put a question out that had the word innovation in it, my ears sort of perked up. Because we are currently working on a very innovative program that I actually shared in my registration when I registered for this cafe. And so I just wanted to share that right now, what we're doing is tapping into the caregiver capacity in order to provide more supports for our caregivers, especially those who have children with very complex needs, very specialized supports that they require. And so we received a grant recently to sort of pilot this program, and we're really hoping that this will be something that can go to a national level. Very excited about it. So what we're doing is essentially matching caregivers with one another, similar to the P2P USA, if you're all familiar, Parent to Parent USA, and they will be providing respite to one another. So we're tapping into that very, very skilled workforce that already has the knowledge, and we're helping them build their village, their capacity by connecting with another caregiver. And so, it's just been such a pleasure to build that program, especially with the lens that we're taking on it. We're looking at it from a very culturally diverse perspective. So we have staff who speak multiple languages. We are currently supporting 5 other languages besides English. And, we're really looking at all of the different cultural considerations for caregivers, what might impact their ability to seek out respite or that connection and that support, what are the best ways to provide that support to them. So, it seems like that reciprocity could be one of those solutions that we're finding for our caregivers. And it's been working out so far, and I just can't wait to report more progress, and share with everyone on a national level, on the state level. So connect with us if you're curious. I can put my information in the chat, but I just wanted to mention that, this is currently something that we're working on.
That's so great. Thank you, Valeria, for sharing. And I think it, sounds like a really exciting program. And as you can see from chat, a lot of people are really interested. But that goes to this larger point. There's a lot of programs I'm seeing that people are chatting about, our clinic is doing this, our group is doing that. And it just kind of speaks to that there is a need maybe for us to think collectively about, of course, there you can publish in a journal about your project or whatever when it's done, but that's not always accessible to people in terms of time, money, and best use of resources. So how are we sharing across these silos and maybe thinking about a mechanism through these cafes or otherwise? The other thing I'm seeing there, Angel, I see your hand, I'm going to go to you in 1 second, is just that word standardization keeps coming up and coming up. Kate really started us off in terms of definition, but I think that there's other ones there, standardization of different things. That it's really challenging because we're dealing often with Medicaid and we have federal and state. And so there's already this challenge, and across states where there's no way to standardize, except, there's been great efforts led by the Packard Foundation and by NASHB to do, national care coordination standards and other, standardization of things for SHIN. And so how can we take those and not reinvent the wheel and use and build upon them? But standardization is the other theme I'm really seeing here too. Angel, please go ahead and share.
Thank you so much. I hope you can hear me. Okay.
Yeah.
Oh, perfect. So I love the talk about family-centered programs and really thinking about family support. I'm actually really fortunate to be a part of a brand new program here in Charlotte, North Carolina, where we are building a pediatric complex care and rare disease program. And we were super fortunate to receive funding from a local foundation that actually experienced really poor care from a healthcare system and had a child with a rare disease and experienced lots of the same things that come with our families. And so we started our program with just our medical director, nurse practitioner, our patient nurse navigator, and then myself as the licensed clinical social worker. So we actually have 4 really kind of good expertise, and we all have our focus, and we're building it around that model. Our nurse practitioner comes from a palliative care and hospice background, so she has a lot to offer for our program. But we are actually taking the care coordination approach to things. We are also taking the family support approach. So myself as the clinical social worker, I'm actually licensed to provide therapy. So I offer 6 free sessions. This is all free anyway to families, but I do 6 sessions with caregivers who are experiencing medical trauma or who have or are having a really difficult time with the adjustment to their child's diagnosis or change in prognosis. And so I do 6 therapy sessions with families, and then beyond that I refer them out if they need additional support or long-term support. And so we're really trying to take the approach of fully wrapping around. Our nurse navigator does a great job of stacking appointments for families. We're also offering a lot of virtual visits. So we do virtual visits on a regular basis so that our families don't actually have to come into a physical appointment. So we're really taking a full biopsychosocial spiritual model approach to things, and we're only a year in, and after about a year our patient load is up to about 115. So we're continuing to expand, but we definitely are pushing the narrative and trying to collaborate across the country, because there aren't many of us in complex care out there, and it would be helpful to really continue to push and ask for more policy change and ask for more funding. But we are certainly in the works, and so yes, just wanted to share that because I love hearing from others, but there is a huge need and we are trying to fill that need, but we need more support from a state and government level.
Yeah, that's the the $1 million issue. I saw that somebody just chatted, I think it was Harry Gawanter that just chatted about we keep begging and begging for more money, and the focus is on how much our kids cost, except programs like the one you just described actually in the end would probably cost less. And there's this whole issue of focus on, investing in children and families as the future. That doesn't often happen. I don't know. I see that Kim, you just raised your hand, but if it's okay, maybe I could ask you to chat your comment. I'm so sorry to do that, but our time is slipping, and maybe we'll get to question 3. Beth Lynn?
Yeah, we'll take just a few minutes for that, and then we're gonna need about 3 minutes to close out. So this third question, really, you just kind of led us right there, which is how do we leverage care innovation? All these things we're talking about that are happening, that people are finding creative ways to be able to meet need and to do so in holistic ways and interdisciplinary ways and working across silos and bring it to scale. So there's more collective power behind it. Let's give people a moment to kind of let that one sink in.
I see from the last question too, Bethlyn, there was some interesting comments about sort of what's the role of commercial and private insurance in all of this, and funding. Several people mentioned, with help from funding from foundations, how do we leverage, go beyond government funding and get some other, investment? But
right. And
hands and
yeah.
Go.
And that's directly related, right? Because that's the money is where's that coming from? So I'm going to start here with Harry. Go right ahead. Oh, Harry, did I lose you?
Oh, Harry, you're on mute.
Oh, oops, it would help if I would learn after so many years to unmute first.
Hey.
I'm going to be the curmudgeonly old pediatrician who has an adult son with medical issues, and say, everybody's talking about innovation and new things. Really, what we're talking about is basic human interactions and human care that requires more people and less technology. And nobody wants to pay for people anymore. And I think that the innovation would be giving everybody more time to spend with families and actually do the care that is necessary and not try to pawn it off on technology.
You've got a lot of amens. I would strongly encourage folks to join us for our May webinar, virtual cafe, where we will discuss, again, robust discussion around humanism and care to meet unmet need. It's exactly to that, and looking at structures. What are the structures? Not just individual clinical relationships, which are important in like training around those, but what are the structures to support that? And time is indeed one of those. And primary palliative care principles, and there are evidence-based and there are small p and large p structures that families told us in our family focus groups was the CMC coin, and that you've seen in many other spheres, I'm sure in your own perspectives and where you sit, that speak directly to that. And yes, there's much in the chat about accountability for organizations around that, and looking at communities of practice around a lot of this kind of thing, so we can share learnings. And there are different types of things happening, and we'd love to take in your ideas around it and see how we work with other people, including Elizabeth Cope is on this call. I'm going to ask her to speak in a minute about work that they are doing to support 5 teams that are doing demonstration projects around CMC. Ruben.
Hello, thank you very much. My name is Ruben Frescas. I'm the chief for the Children with Special Health Needs branch for the state of Hawaii, Department of Health.
Great.
And great discussion. Again, thank you for coordinating these series of cafes. Just wanted to share here in Hawaii, one of the innovations that we're trying to integrate and use is the Blueprint for Change framework, and revisioning that as a way of trying to look across all the programs that we offer through the state, and really try to look at it through fresh eyes. So strategizing how each one of our different programs actually collaborate, build on each other, and trying to improve some of the department to department interactions and engagements. So for example, we initiate and do early intervention screening for children, but then Department of Education takes that over after 3 years of age. So trying to improve the coordination among the various departments and the responsibilities that we have to care for children and families as they transition. But also working with our Medicaid partners as well, working with our professional societies and organizations. So we've utilized this Blueprint for Change framework to look across things in a more holistic and comprehensive way. And we'll be actually engaging in this multi-stakeholder external meeting later this summer. But all of this has been sort of the worksheet, if you will, to help frame our 5-year strategic plan. So from 2025 to 2030, we'll be looking at how these different elements actually engage, interact, in order to try to strengthen, optimize some of the work that we're currently doing. But we're also identifying the gaps of things that need to be improved across 5 different areas. So just to highlight policy, for example, workforce, financing, engagement, and sorry, I'm blanking on the last one. But looking at how each one of these different elements will then inform specific actions within those cross-cutting areas. So, I think that that's a good opportunity for us to leverage and use something that does have some common language and understanding across different states, but then how that gets applied is very important. And what we believe here is that engaging across our different partners is extremely important. And that includes families, people with lived experience, and those who have personal experience with this.
Fantastic. We'd love to talk more with you about that, everything you just said. So we are at 3:58. There's so much more. I thank you so much for everything that you've been bringing into the space. And I know it feels a little bit like a game of ping pong. We've been all over the place, but part of that was the point, to be able to really look at the breadth of where we're at and really just start to generate some energy, ideas, really see where we need to go next. The evaluation will help us to think about that too. So please everyone's here because we recognize there's things that we need and ways we need to figure this out. And we're all a part of that. And there's lots of ways we can help work with others that we know of and leverage that. I want to at this moment say, Anna, I see that you have a hand. I want to say we are put some stuff in the chat about the next virtual cafe, and that one, please, I mentioned it, and you can register. I'm going to drop an evaluation link in the chat in a moment. We have yes, we absolutely will set up the schedule. And I want to say that if you could possibly put in the chat what you have, since we only have 1 more minute, I want to make sure we have a special guest today, Elizabeth Cope, who is with us, and I need to give her a moment to be able to share with you another exciting possibility for being able to come together again. She's Vice President of Health Systems Improvement at Academy Health and Principal Investigator for Enhancing Systems of Care for CMC Coordinating Center. So Elizabeth, do you want to just take a minute and share about some exciting learning that you have, opportunity you have?
Yes, thank you very much for that kind introduction. And I am just going to make a quick plug because I know this is the last minute of this. So just to say, please join us. So this was a fantastic event, by the way, and I'm very much looking forward to the next one. And just want to say to please join us on Tuesday. This is April 23rd from 12 o'clock to 1:30 Eastern Time. We're going to have a webinar that's introducing the HRSA MCHB funded initiative that's entitled Enhancing Systems of Care for Children with Medical Complexity. I'm going to drop a link to the registration in the chat. Let me just do that real quick because I know people are jumping off here. This is a 90-minute session that's going to offer a comprehensive overview of the initiative. Specifically highlighting the 5 demonstration sites that are all dedicated to developing new care models for children with medical complexity. We're also going to feature firsthand perspectives from a parent caregiver alongside a provider to set the stage with a discussion about strategies to enhance patient engagement and advance equity in care. And of course, there's going to be time for open Q&A from audience members. So again, I put that registration in the chat. And thank you for giving me a minute to make that announcement. And we hope that we see you all there. So thank you.
Absolutely. Thank you. Like we said, we all matter, and it's really love being able to leverage this together and share. So the last thing to just say is please make sure if there's so much here. Thank you, everybody. Such richness, and please share whatever else you can think of in that evaluation. It will really help us to think about shaping this and anything else that we could all do together and feed to our network of people we work with to think about how we better serve the field and grow and innovate and do all these questions we said to help move them forward. Contact us anytime. So, and anything else you want to throw in the chat now, feel free to, and we will see you in May, and reach out to us anytime. Thank you so much. This is a fantastic discussion, and it is a community, and we appreciate getting to be together with you all. I also want to make sure everyone's aware of, I'm going to throw in here. Oh, and there's Karina's beautiful artwork. Oh, Karina. Thank you. We will share this all out in the recording, and we'll also synthesize this to bring to all of you and package it for people to be able to share out as well. Thank you. And this, I'm just putting in this now, is a little bit of a thank you. It's a fantastic, meaningful discussion for everybody because of you all, because this is, so thank you for that community. And I just wanted to throw in the chat Kara's the Bluebird Way website too. Great, I'm gonna stop recording. Give people a moment if they're hanging around and